Now we are planning for upper full mouth for this completely periodontally involved patient. 6 implants, 2 pterygides and 4 implants on the premaxilla, 2 tilteds and 2 axial. First we will see the reformatted image. So a gross idea about the bone loss and bone level we can see from this 3D reformatted view. We can observe the severe bone loss in the left quadrant. Post tooth loss, there is complete alveolar bone loss. Even the bone loss is still the zygoma level, zygomatic buttress level. So first we will plan the pterygides on both sides. First we will see the pterygide right side. This is the right side pterygide. It's a quite easy pterygide. 7 there is bone loss, luckily 8 there is no bone loss, so it is favorable. So the crustal part of the implant will be safer. And between the sinus, posterior sinus wall and the distal aspect of the tuberosity there is enough bone, and this pterygoid junction is also favorable. Even the tuberosity bone itself is good cortical. So our plan is to start from the edge of the socket. This is a descending palatine canal coming down, so we should not target that one. Just below that we will see in the cross section. Buccolingually we will see the cross section. So this is the buccolingual cross section. Okay. So it is showing in reverse. This is the medial pterygoid, this is the lateral pterygoid. Almost 15 to 16 mm length. You can place implant. Okay, so this is the pterygoid fossa. Our aim is to enter the pterygoid fossa or just medial to the pterygoid fossa. So we are planning for JD implant, 3.715. We will see the left pterygoid. Almost similar. There is no 7, only 8. From the crest of the 8 we can start. And this angle will be better. If we are directing towards this radiolucency, which is the descending palatine, we will be entering the canal space. So we will be entering this. For this patient, the descending palatine canal is very huge, and there will be severe bleeding also. We can place only 11 mm at this angle. So when doing pilot drilling, take IUPA. If it is directing towards this direction, just change the angle more distal. Now will be more safer. Okay. So this is much better. Same around 15 mm, something like that. Now we will plan the right tilted. This is the molar. This is the second premolar. Severe bone loss till the apex. Only 2 mm bone between the sinus and apex. So don't start from the socket depth of second premolar. Otherwise the bone above the crystal part of the implant will be very less. It will resorb and we will end up in failure. So the starting point should be from 4 and 5. So you have enough bone surrounding 360 degree of the crystal part. So starting point we have finalized. What is the ending point? If we go like this, we will enter the sinus. So what we will do in this, we will be tilting mesially. How much mesially we will see. So at one angle we are getting this huge buttress, which is a great advantage. If you tilt little more mesial towards the nasal corner point, what we are getting is a lesser one. So there are two options in the target areas for the tilted implant. One is this nasal corner point and another one is this buttress. So we will see where is this. So this is almost in the buttress area. We are getting longer length here. If we drill parallel to the buccal wall, if we drill parallel to the parallel wall, we will be getting only lesser length, only 13 mm. But if we drill parallel to the buccal wall, we will be getting 15 or 16 mm, and also the abutment also will come in the better position. And what we can do is we will tilt little more distally. We are getting more bone. So we will find out where is this target point. So this is the buttress area. So instead of targeting the nasal corner, we can target this area. So expose this area, mark it with pencil, mark the entry point between 4 and 5 from this edge, and we can do the drilling. This is right tilted, left tilted, left nasomaxillary buttress. We will see. First we will check the nasal corner option like this. So if we are focusing the nasal corner, that is the widest point of the nasal floor, the anatomy will be like this, and where we are starting is from distal to the canine. So this is the canine, distal to the canine, first premolar. The second premolar area we can start and tilt it mesially. So this is towards the nasal corner. Now we will tilt towards the buttress area. Here we are getting little more longer bone. But however, we have to go parallel to the buccal wall, lateral wall. Then only you will achieve this maximum bone implant contact area. If we tilt palatally, it will be only 12 mm. But if we tilt parallel to the buccal wall, we can get longer one. And there is a small relucence here, that is the canaliculus cyanosus. There is nothing to worry. It is a normal anatomical feature which we can see in all patients. There is a depression here in the lateral wall. There is a depression here, that is a canaliculus sinus or cyanosus. So anterior to axial implant, just lateral. So this is the nasopalatal canal. The cross section is a little heart shaped. Two implants lateral to the nasopalatal canal. That is probably in the between central and lateral. So most of the time it will be in the central and lateral. So mild palatal approach, instead of going like this, we are going palatally. Fortunately, the nasal cortex is very thick, 3 mm, and very cortical, and this bone is also good. By palatal approach, 1 or 2 threads may get exposed palatally, that's it. 3.7, 13. So this is right side, this is right side. Here also we can apply the palatal approach, because the bone width itself is 3.7 only. So we are planning for 3.7. We have to start the drilling palatally by palatal approach. So that's it. The challenges will be bleeding after extraction of right side, severe chronic inflammation. That will be the one challenge. Canine maybe buccal plate may get fractured. That is also one more challenge that we have to be careful. Apart from that, it is a straightforward situation. Checkpoint 1 lakh.